So welcome everybody to this webinar, which is looking at neonatal care focused on those working at an enhanced level of practice. And this session is going to be particularly focusing on palliative care in neonatal care. And I'll soon be handing over to our clinical expert, Katy, who'll be taking us through the presentation. But just before I do that, just a reminder that you can use the Q&A function here. So if you have any questions or things that you would like further information about or clarification about, do pop that into the Q&A and we'll have some time for responding to those at the end of the session. The session is being recorded, so you'll be able to watch it back later on once we've had the transcription done or added the subtitles. So with that in mind, I'm going to now hand over to Katy, who will take us through the presentation. Katy, over to you.
Thank you, Sally. Hi, like Sally said, this is the Neonatal Occupational Therapy webinar for enhanced level practitioners. And today I'm going to talk about the role of occupational therapy within neonatal care, within palliative care. So my name's Katy Fox. I'm children's occupational therapist and neonatal occupational therapist, and just a little bit about my background. I've worked in Clare House Children's Hospice, which is on the Wirral. I've worked in Glenclwyd neonatal unit, which is a level 2 unit, and now I'm currently at the Countess of Chester neonatal unit, and that's a level 1 unit. Okay, so this webinar is part of the NHS England programme. So it's part of a collaboration between RCOT and NHS England to shape the future AHP workforce. It can be used by people in all 4 nations, and it's focused at OTs already working in neonatal care and is aimed at those enhanced practice, and it is part of the wider blended programme. So there isn't it's kind of in collaboration with the other webinars that are available on our RCOT website, which include occupational performance, pain and stress, and models of practice, so that it's designed to kind of run alongside those. So just briefly, the session today, there'll be an introduction. I'll look briefly at frameworks and guidelines. We'll look at what is palliative care, what's the role of OT in palliative care. We've got a couple of case studies and looking at practical application, and then there's time for a link for reflection and time for questions at the end. Okay, so learning objectives. By the end of this webinar, hopefully you'll have an understanding of what palliative care means. We'll recognise the impact of the palliative care journey on the parents and the infant using the person, environment, occupation model. We'll understand the role of neonatal OT in palliative care, and then we'll look at how we can put it all into practice. So first of all, we'll start there's some reference here for frameworks and guidelines. So I've kind of started broad and then gone kind of narrowed it down. So we have NICE guidelines and we have a BAPM framework as well, so that all the references are in at the end of the presentation. I've also put in, there's a neonatal palliative care project. So this is led by Alex Mancini, who is she's a neonatal palliative care lead for the UK, and she runs lots of, if you are interested in kind of looking at this further, her email is at the bottom. She runs lots of training sessions, and she is actually working with the ODNs across the UK, looking at how we can improve the experiences of parents and infants going through the palliative care pathway. There's a career pathway that it's actually in draft form at the moment, but this goes alongside the NHS and Health Education England guidelines, and this is palliative care, and this is hopefully to improve future supply of aspiring specialist nurses and AHPs who have a real interest in working in palliative care and looking at education and developmental opportunities. Then you'll have your ODN kind of pathways and guidelines. That's a good place to start. So I'm in the Northwest ODN, so that's why I put this reference in. And then you'll also have your trust wide. So this is, I've recently worked in Betsy Cadwallader Trust, and this was our kind of local guidelines. So this is often a good place to start to find out kind of who the lead is on your unit and what practices are in place already, if you have an interest and would like to take it further following this webinar. So what do we actually mean by palliative care? So essential, fundamental, crucial, vital, and embedded into routine neonatal care. Palliative care for a fetus, neonate, or infant with a life-limiting condition is an active and total approach to care from the point of diagnosis or recognition throughout the child's life, at the time of death and beyond, and embraces physical, emotional, social, and spiritual elements, and focuses on the enhancement of quality of life for the neonatal infant and support for the family. This is from the reference to perinatal pathway for babies with palliative care needs. And I just think every kind of, that whole definition kind of fits in with the role of OT in our holistic approach to therapy. So in recent years, referrals for palliative care from the perinatal and newborn period have often been the starting point for long-term follow-up of children with complex chronic conditions and special healthcare needs by palliative care clinicians long after the infant has left the NICU. So I've put this in now. So this is from Together for Short Lives, which is a palliative care charity. And I just wanted to show, when I first started working in palliative care and first started at Clare House, I think my kind of idea of palliative care was that it was babies and children who were imminently kind of going to pass away or die. And when I started working at Clare House, kind of my whole idea of palliative care changed. And I think this sums it up really nicely. So this is a category of conditions which sets out 4 broad groups of life-threatening and life-limited conditions, and their which is illness trajectory. So it's so important for planning and needs, and it shows how palliative care actually is so broad and can change at any moment that we have to kind of, you'll often hear the phrase parallel planning, which is plan for the worst and hope for the best. And I think this diagram kind of sums that up, as does this one too. So this is again from Together for Short Lives document. So this is diagrams to illustrate the various patterns of relationships between palliative care and treatments aimed at cure, and how they can be quite transient, and kind of the infant or baby can move through these kind of 4 categories. And again, parallel planning, so we plan for the worst and we hope for the best. Okay, so what is the role of OT within palliative care for neonates? Essentially the same as the role of OT within neonates. It's not any different. I've put a reference in for our guidelines there, and we have practice guidelines that provide guidance and define our role on the unit, and always a good place to start, and always a good idea to keep going back to our guidelines. Essentially the role of OT with neonates is the same as with palliative care for neonates. So I've put this slide in, and I just think it's a really good place to start. So just parents, just kind of essentially, without having the palliative care element, just being on the unit, parents have a loss of security, loss of ideal, loss of normality, loss of friendships, job control, rest, confidence, hope, identity, roles and routine. The journey, often through pregnancy, has been less than ideal, separation from infants, from wider family support, fear of an actual loss, witnessing stress, pain, suffering of their baby, and chronic uncertainty. Okay, so I've put a paper in here. So Hobbs and Lee noted that for parents coping with having a child with disabilities or losing a child, a common factor to the occurrence of chronic sorrow is a disparity created when the desired or expected relationships differ from the actual relationship. So early parental co-occupations are affected, and this may be difficult for parents to attach. So part of our role is to help and facilitate positive family interactions, and this should be highly valued. Moments of co-occupation, they may not occur frequently, but engaging in co-occupation may be seen as a symbol of moving towards normal family life. A paper by Redshaw et al., actually entitled "This is the Time We'll Never Get Back." This is a qualitative study, questionnaire sent to 249 mothers with a 78% response rate, and their findings identified what is the most important for mothers in experience the life and death of a baby as a newborn. Physical contact with their baby, being treated as a mother and parent and being able to function as one, and sensitive and responsive care, and actually being heard. Okay, so I've just put some aspects to consider when we're thinking about our role on the unit. Okay, so we talk about communication pearls and how we're going to communicate with our parents. So these include asking and being silent, asking questions like, tell me about your baby, what are your worries, what are your hopes, how can I be helpful? And this is all validating the actual life of their baby, and listening and giving them privacy and compassion and time to talk. Spirituality and religious support as well. You'll have we have a pastor that comes onto our unit, and you can link in with those. So we look at spirituality and religious support as part of our holistic approach. Now, spirituality is often seen as is more wide in scope, and religious care is generally considered to be more narrow and tailored to meet a set of beliefs a family holds as a result of belonging to a faith. So, for example, wanting to get their baby christened. And spirituality care could involve beliefs around life and earth and life and death, and searching for meaning and purpose throughout both the periods of illness and death. But there's references in at the end of this presentation if you'd like to look at that more. Okay. Practical thinking, so collaborative working and team working and MDT working. Who is the best person to work with their family? How are we linking in with families' goals and medical goals? And sometimes it feels like you're not kind of doing enough, but often just being with the parents and just letting them talk to you, making them a hot drink, hand on the shoulder, just listening to their story is massive. And that's part of our role as well. What makes a good day for your baby? What can we do to support you to have more of these good days? And how do we enable and support nurturing family experiences? And then I've put journey making and memory making. So a journey box that then may become a memory box. But again, we're thinking all the time about parallel planning. So we're preparing for the worst, but we're hoping for the best. And we don't know the outcome. We don't know how things are going to kind of pan out. So handprints and footprints, supporting parents to do handprints in a least stressful way. So looking at how we can support the baby whilst the parents doing that. So we're looking at hand hugs and hand flexion, containment, hands to face. We're looking at kind of dabbing and inkless prints rather than light feathery touch, so that we're not stressing the baby out. And we're giving affirmation that their infant's life had a meaning, no matter how short. And then this is also how are we going to support parents with additional needs. I've recently worked with a mum who told me that she had a diagnosis of borderline personality disorder, and she found particular times of the day really stressful. So, for example, ward rounds, and often would disengage at this point. So we chatted about what strategies she uses at home and what helps her, and listening to music and having her earpods in at different times. So we looked at how we could kind of facilitate that for her. So our parents may have additional diagnoses, so ASD, ADHD, trauma. They've been through trauma from day one when their babies were born and separated, sensory processing challenges, thinking about our language and how we talk and talk to our families. So, and the assumptions that we make. So why are our families not present? Feelings of guilt, terrified, money worries, transport, siblings at home and work, and how are we going to support parents to be there with their baby. Okay, so now I'm going to talk about, we've got a couple of case studies to hopefully put what we've discussed kind of more into practice. So case study 1, Alice is a baby girl born at 40 plus 6 weeks in a midwifery-led unit. She was born floppy and in poor condition with her cord wrapped around her neck. No heartbeat or respiratory effort. She was given chest compressions and inflation breaths. And active cooling started 3 hours after birth. In total, she was intubated for 3 days. She was on high flow, self-ventilated in air, and then back on high flow. She was weaned to low flow and then remained on low flow of 0.1 to 0.15 litres per minute. She was given a diagnosis of grade 3 HIE with acute kidney injury. She was transferred to a local hospice after 1 week. She had hypertonia, she was heavily sedated and repetitive jerky movements, and was still having seizure activity. She was first mum to a young parent, 20-year-old. Mum was an admin assistant and dad worked at an ice cream factory. Previously homeless, due to moving to a new home in 2 weeks, and dad has previously been in care. Both parents at the cot side and fully involved in all cares. Okay. So like we said before, the OT model that we're going to use to frame our practice is the PEO model. So looking at parents, so first baby to a young mum. So we've said she's 20 years old. Mum is an admin assistant and dad works at the ice cream factory. Previously homeless due to moving to a new home in 2 weeks. Dad's been in care. Lots of what ifs and fear of unknown. Now for Alice, to kind of look at and frame Alice as a person, I've used Bradleton, so adaptation of the synaptic theory. So this will give an understanding of her infant behaviour. So using the AMORE acronym, so autonomic, motoric, organisation of state and responsivity. So Alice would often desat during handling and in particular nappy changes, showing paleness around her lips and increased respiratory rate. She showed jittery motor movement, which was seizure related, right upper limb constantly moving, and then generalized hypertonia. She was either in active sleep or fussy and kind of nowhere, kind of fast transition and kind of never really settled. And mum was really questioning quality of sleep. Very small time in quiet alert and a weak cry. Okay, so environments. I think a picture says 1,000 words. This, NICU versus uterine environment, NICU versus home, and how this is going to impact on Alice as a baby and parents and their attachment and bonding and attunement and being parents. We looked at how we could make it more of a home environment. So mum bought pillowcases in from home, so we put those on the pillows around the cot space, and she bought some photos from home. They were in a middle bed in an open ICU, so quite noisy and bustly. And mum would often say about different staff and consultants of the week and how this kind of impacted on how they felt in the morning, depending on who the staff that were on duty. Okay. So occupations that they need, we need one and have to do. So cares, nappy, feeding, dressing and bathing, really advocating skin to skin and positive touch, interacting and bonding, temperature, heel sticks, cranial ultrasounds, medical examinations at ward round, and then other roles and expectations of the parents. So time off work, who's going to do the shopping and make sure that they're eating, washing, sleeping. Dad liked to go to the gym, that was his kind of time out, and mum enjoys reading and seeing friends. So occupational performance. So I see this as kind of the experience and the outcome and the goal of kind of attunement. How are we going to improve quality of life, decrease stress for Alice and her parents, goals achieved and memories made. So goals for the family. So mum and dad's goals were to be Alice's mummy and see her suck on a dummy like a baby. They were her words. To be able to take Alice out of her cot without waiting for a nurse to help, and to spend longer into skin to skin, and to give Alice a bath. Okay, so I've just split the goals. We're just going to look at the goals more individually. So to be Alice's mummy and see her suck on a dummy like a baby. So we did lots of MDT work in, and I did assessments and interventions with our SALT, with our speech and language therapist. So for non-nutritive sucking assessment to see if dummy dips can be offered during nasogastric tube feeds. So when we did this, she had minimal swallow heard, but SATs remained okay, but her respiratory rate did increase. So she was able to have dipped and well-shaken dummies to be offered during feed times. During working with the physio, so we're wanting to improve and promote good positioning, so looking at flexion and alignment and encouraging our hands to her face and to midline for regulation and to reduce those involuntary movements and to promote better quality sleep. And I also sat and listened, and I made hot drinks, and I helped Mum to make a photo album. And Mum spoke to me and said that they're not religious but wanted Alice to be blessed and believed she would go to heaven. So I made sure these wishes were shared with our bereavement lead nurse. Second goal, to be able to take Alice out of her cot without waiting for a nurse to help, and then to be able to spend longer in skin to skin. So I worked with Mum and Dad to do wrap transfers to be able to get Alice out of her cot on her own. We talked about talk, touch, and then move, so the 5-step dialogue. And then we look at, you know, the importance of the sensory environment. So we know that if baby's can't be in utero, then the best sensory environment is skin to skin. So how are we going to facilitate that? So she startled with noise and on handling. So by doing the wrap transfer and keeping that flex midline position with hands to face and moving it onto a side and bringing it out that way, we reduce kind of that startle. We made sure it's dim lighting and quiet, and thinking about the parents, are they comfy, and like we said before, the pillow from home and photos around the bed space. And you know, not just about doing longer in skin to skin, but the quality of skin to skin for both Alice and her parents. Okay, so how did we support skin to skin? So Mum used Zaki Zak, which is one of the Zaki wraps that I put a picture on. So we positioned Alice on Mum's chest with the help of the nurse, and she had a tendency to push back into extension. So we were able to maintain a better position with Mum's chair further reclined, provided Mum with a hand mirror so that she could see Alice's face, and then took lots and lots of photos and sat with Mum. And Mum then, that's when Mum was chatting about that she doesn't really think that Alice gets much quality sleep. And again, we were able to talk about that the best quality sleep she would get would be in skin to skin on Mum. So Mum did remark on this. And then I've just put this slide in. I know we know about the benefits of skin to skin, but I don't think you can say it enough. And I just think if you're getting these slides at a later date, then you'll have this as kind of a reference. But we know that skin to skin can reduce stress and pain for the baby, regulate baby's body temperature, breathing, blood sugar and heart rate, promote bonding and attachment, lowering the risk of postpartum depression for the mum. And then I know I've put there long-term cognitive gains, but like we said, parallel planning, we don't know what the future outcome is. And working at Clare House kind of showed me that we don't know what is around the corner. Okay. And then the third goal, so to give Alice a bath. We have a unit leaflet with a QR code, so parents can watch a little video first. Demonstration with doll. So using a muslin helped to support Alice and reduce her jittery movements and that startle reflex. Dad held Alice and Mum washed her. She did have some spit up and twitching of upper limbs, but generally was okay and in a calm, alert state. Some crying when transferring from a bath to a cot for drying. I chatted to parents about undressing and dressing, one limb at a time, whilst the other offered hand hugs and frontal pressure to support Alice. And then we chatted about thinking about skin to skin straight from the bath and massage, but the massage wasn't appropriate at this time. We videoed the bath and took photos. There was definitely brief eye contact between Alice and Mum at that small kind of window, that attunement. And this Mum reported that this was the first time she actually felt like Alice's mummy. And Dad was talking about carrying on wrapped bathing when they get home. And then we put a little photo album together to share with grandparents. Okay, so case study 2. So this has been provided by Ben Harris, so he's OT in Birmingham, so thank you, Ben. So this is Mary, baby girl born, she was 36 and 6 via emergency cesarean due to reduced fetal movement at a level 3 centre. Born with significant hypotonia and minimal respiratory effort, so she was intubated and ventilated at birth and then weaned onto CPAP. Continued to present with low tone throughout her body, and investigations were commenced, and was found to have a very rare genetic syndrome presenting with significant hypotonia and congenital contractures. At 38 weeks of age, following the results of genetics, they fed back to parents and they had a discussion with neurologists, neonatologists and palliative care. And Mary's care was reorientated to be comfort focused, and an advanced care plan was put in place. Okay, so we're using the PEO model. So second child's parents with an older sibling, Sarah, she's 5. Parents present on the unit every day and they both stay for long periods of time. Dad, James, leaves to pick up the older sibling from school and they occasionally have support from family members to do this. So Mary, again, we're going to use the Brazelton kind of synaptic theory adaptation of. So we're looking at the AMOR acronym. So A, autonomic. So she desaturates and significantly increase in heart rate during periods of examinations, transitions within and transfers out of the cot. Colour changes, mostly flushing around her forehead and cheeks. Motor, small amounts of movement in her neck, shoulders and upper arm, but generalised hypertonia and difficulties coming into that flexion and midline posture, that most settling calm position. She has real trouble getting into that position. She's predominantly in a sleep state unless having cares or transitions and then moves into a drowsy and fussy state or fussy state. She responds very quickly to her mother's presence, voice and touch. So thinking about the environment again. So again, pictures, 1,000 words. It's a level 3 unit in an IT nursery, so it's very busy. We're thinking about the sensory environment and kind of the mismatch between the ideal sensory environment and where she is. There's not much space between the cot spaces for parents. Different staff on duty lend to different experiences, and there's only one reclining chair. So again, parents are having to swap when carrying out skin to skin. Occupation. Both parents wanted to be as involved in aspects of Mary's care. They were both also very focused on ensuring that Mary was comfortable and not in pain or distress. So goals included wanting to gain confidence in supporting her baby and completing cares. Helen, whose mum especially finds nappy changes challenging and wants to advocate Mary's cues to others around her. James reports he would like to have Mary out for more skin to skin. He would particularly like to build confidence in handling Mary as he feels she is delicate and doesn't want to hurt her. Okay, so what did we do? What did vendors note? So wanting to advocate Mary's cues to others around her. So when parents aren't there, this is, Mary's voice, and parents know Mary's as an infant and not just a baby in the incubator. So inviting Helen to complete joint observations. What can Helen tell us about Mary? How can we develop an understanding of who Mary is and her ways of communicating, her strengths and areas of need? As part of these observations, Helen had also wanted support on how she can teach Mary's sister, Sarah, to develop a relationship with her sister and do this in a supportive, responsive way. Occupational therapists supported Helen to identify some easy and supporting touch and auditory-based strategies for Sarah to engage with her sister. And then second goal, developing confidence in nappy changes. So occupation-based assessment, listening to Helen's breakdown of the activity. Which bits are working well, which bits aren't working so well, and what could be done different. Identifying strategies for comfort and reducing stress. Use of side lying to support posture and breathing. Use of wrapping to facilitate midline and containment, and slow sequence through the activity using pauses, and Alice using still touch to support at times of sensitivity, so the AMOR acronym. Dad's goals included increasing confidence in handling, so using a graded approach, starting with watching and completing joint observations with James. What can James tell us about his baby and how she's communicating? Moving through to bringing hands into the cot and promoting opportunities for James to use still touch to interact with Mary, as well as identify touch support strategies. Practice increasing movements using wrapping with the cot to support moving into new positions, and working on slow, smooth movements, reducing additional vestibular stimuli. Preparation for transfers out of the cot, again using the wrapped approach. And then Dad's second goal, increasing confidence in skin to skin. So parents had identified that they did not wish to lead transfers whilst Mary was on CPAP. Therefore, working with nursing staff on wrapping and close holds to facilitate Mary's stability. Identifying positions of comfort for Mary and for James, and scaffolding an environment in which Helen became involved in supporting James and Mary as needed, spending meaningful time together. So to wrap it up, I've kind of put some take-home messages just to kind of think and reflect on. So you cannot grieve if you do not have a relationship. We only have the choice you gave us. So Nadia Leek is a parent who works with the AI Smart team, and these are her words: we only have the choice you give us. Do with, not do to. We are part of their memories. Ordinary moments of co-occupation. So they'll be small and fleeting, but they're there, and it's our job to kind of enhance and facilitate those. And then parents, these comments stick with me every day when I'm on the unit. So from AI Smart training, so parents, so that just being a parent on an neonatal unit is disorientating. One mum said, I didn't know if I should sit, stand, ask questions, take photos. I felt like I needed a permission to be a mum. I was in devastating, utter darkness. And then this one in particular: be genuine and don't come with a script. And if you say you're going to turn up at a time, please turn up. Okay, so further resources and sources of support. So we've got our neonatal guidelines, we've got the foundation level e-learning program, and then we've got our RCO2 kind of specialist section and all our enhanced modules together. And then I put all my references and further reading here if anyone wants to look kind of further into palliative care. And now I'm going to hand back to Sally.
Katy, thank you so much for that really enlightening presentation that you've given there. I'm learning so much from you and your colleagues, and I think if we can do occupational therapy in neonatal care, I think we can do occupational therapy anywhere, can't we? You're so occupation focused in your approach, and I think your presentation to me has shown that palliative care in neonatal care isn't something separate and different to what we're doing already. I think that came across really strongly, and having attended the previous webinars, actually you're doing what you're doing anyway. We still want to support parents to be parents, to carry out their parenting role in the best way possible for, you know, whatever time they have with their infants, and to make sure that their infants have that best possible quality of life. And that's absolutely come through really, really strongly. And I think the other points that I picked out there is that we don't know what the outcome might be. So that planning for the worst, but hoping for the best, and planning those parallel journeys, that neonatal journey, I think is again something that's come across really strongly. So if you're watching this and you've got any questions, then please do post them in the question and answer. Use that option there. But just before we pick up any of those, Katy, I know that working in palliative care is really, really challenging, and you've given us some great examples of the things that you do. Is there anything else, any other top tips or thoughts that you want to make about the challenges, the particular challenges of working in neonatal palliative care?
Yeah, I think it's kind of that balance between who is the best individual to work with the family at that time, not overwhelming the family, and thinking about kind of parents' goals versus medical goals, and who's best to kind of help facilitate those, but also not feeling that you need to do all the time. That was a big learning curve for me, that just being there, a hug, a smile, are you okay, hand on the shoulder, do you want to step out and get some fresh air, it is enough at that time. And it will impact you. So working at Clare House as well, before kind of I worked with babies there as well, and it will impact you, and that's okay. And it's kind of time and reflection and talking to people if it is upsetting for you, and attending the debriefs and looking for that kind of support, wider support. Yeah, and
Absolutely.
That big learning curve is all that palliative care, isn't it? Imminent dying and death, it is a whole spectrum and a whole scope, and really rewarding.
What support and information have you made the most of to look after yourself as an occupational therapist in these settings? What strategies have you used?
So often on the wards, we have, following the death of a baby, we'll have debriefs that are free, you know, all staff can attend, and kind of support of colleagues as well and supervision, but kind of and at Clare House as well, we were really lucky to have a wellbeing team and complementary therapy team who would support the staff. But knowing that it is difficult and it is hard, and it's good to talk and to reflect. Yeah, and kind of attending those debriefs as well, I think that they really help, and asking your questions as well, and don't being afraid to ask. No question is too small or daft. Why did that happen? How, you know, and because people have got more experience and been there longer, so they can help you in different ways. So I think talking and not kind of bottling it up. Yeah.
Fabulous. Yeah. And I guess there isn't a particular role for, you know, you don't have your neonatal palliative care occupational therapist. It's part of everybody's role.
Yeah.
So being able to draw on the skills and experience of others who've been there longer,
Yeah.
I guess, is important.
Yeah, absolutely. Yeah.
Yeah. And tell me about a little bit more about the importance of working as part of a multidisciplinary team with these infants and families.
So, as I said in one of my case studies, we work really privileged to work with really great speech and language therapists and physios, and we work, you know, almost as kind of developmental therapists across, you know, on the neonatal unit. So I think it's really important to kind of think about the parents' goals at that time, and not being a kind of a part of a tick box as, oh, I've seen them stay and then it's your turn. It's, you know, it's what's best for the parents, who's got that best relationship, what are the parents' goals, kind of who's the best one to work at that time. But it's not just your AHPs too, it's working across the board. So we have children's hospices who come in to support families, and how can we work with those, bereavement lead, the nurses, the doctors as well. So it really is across kind of a wide spectrum. But I'd say that within AHPs, it's who's best to work with that family at that time and meeting their goals. And yeah,
That's a really important point, isn't it? That, you know, I think sometimes as any professional, you get a little bit worried about giving away some of your skills. You know, so you might be suggesting that the speech therapist supports in a particular way because that's come up in your work with the family, but actually that's the right thing for the family and that infant, isn't it?
Yeah, absolutely. And working closely, you know, if something comes up and you think that it is more suited to another HP, then you know, it's just communication, isn't it, and working together for the best outcomes for the family and baby.
Yeah, absolutely. Having that at the forefront of our mind has to be the priority. Brilliant.
Yeah.
Okay, I've got a question here, which isn't perhaps specific about palliative care, but when writing clinical notes, do you use the AMOR acronym? And if so, do you find that other professionals get what we're talking about, even those that haven't had Brazelton training?
Yeah. So when I worked in North Wales, we used Therapy Manager. So they were just AHP notes, and I would use the AMOR acronym then. And then when I wrote in the medical notes, not so much, but I'm trying to do myself templates for kind of to combine the two, but I will use the AMOR acronym and then in my analysis kind of bring it all together. So I might, and then rather than just write AMOR, autonomic motoric, but then in the analysis bring it all together. So yes, I am hoping to use those in my new post as well.
Fabulous. I guess that's part of the education of the wider team, isn't it? And I think having that framework is a really helpful one to communicate more about what the approach that we're taking.
Yeah. And I think as well, behavioural cues is babies, nothing that a baby does is by accident. Behavioural cues is kind of should be the forefront of everyone. And so if we can all get in, you know, Brazelton approach isn't an OT approach, it's a whole kind of, it's an approach for everybody working with infants and babies. So I think the more we can bring that into kind of our work as well.
Brilliant. It's about having that balance between the approach that is the approach for the unit, but then bringing that occupational therapy lens. And I think you've articulated that really well, and it's come across in the other webinars as well about the unique role that we have in supporting parenting occupations as well as the infant occupation. So that's really good. We have a question here about whether you use COPM for goal setting, and I know that's something that's come up in the previous webinars. Is there anything that you'd like to say about outcomes?
Yeah, so I haven't used it as yet, but it is on my list to look at how I can adapt it. And I know that's a kind of a project in the wider neonatal OT world, but looking at how I can use that as an outcome measure for kind of goal setting with parents. But I haven't used it as yet. But it is on my list.
Fabulous. So I think I'd refer the person that posted that question back to our previous webinar. So go and have a look through those, and you'll find some really good examples of illustrations of the COPM being used in practice across neonatal settings. Fantastic. So my final question to you, unless anything else comes up in the Q&A, is about people that are wanting to find out more about, or to develop their skills and confidence, I guess, to work in to upskill in palliative care in neonatal settings. What would your advice be to them?
So on your unit there will be a bereavement lead, so go and chat to those, find out your local guidelines and what's in place there, and then absolutely I've put the reference and the link for Alex Mancini as well, who's neonatal lead nurse for putting the palliative care project into place, and she runs and they used to be weekly but they're monthly now, so kind of training sessions that anyone with an interest in palliative care is free to attend. So I think that's a really good place to start, but definitely get in touch with your bereavement lead on your unit and see what's kind of happening where you are first.
Fabulous. So starting at that local level, as you illustrated really well at the start of your presentation, and finding out what local support there is, and then looking more widely at what's happening nationally. And of course, we've got the neonatal clinical forum is really active, isn't it? And a really good source of support. Yeah. Fantastic. Okay, well, thank you everybody for your questions and comments. Katy, could you just move on to the next slide, please? Just a couple of things before we finish. Thank you. And the next one. So having watched this webinar just now, we would encourage you all to go and have a look at the RCOT 5-minute reflection tool. There are some links to it on the RCOT website. And that's a really good way to capture your learning, to think about how you're going to take what you've learned from this webinar, whether you're working in neonatal care or it's something that you'd like to do. Think about what your next steps might be. And of course, that's a really good way to evidence your learning. You can upload it to the new RCOT CPD portfolio as some evidence. So that's great. And the next slide, please, Katy. And we have a feedback form. So if you could follow the link and give us some feedback on the webinar, what you enjoyed, what was good about it, how are you going to apply your learning, and if there's anything else that you would like to know, that will help us inform what we do next and what the members of the Neonatal Clinical Forum might focus on for future learning and development opportunities. So your feedback is encouraged and really welcome. So thank you for that. And the next slide, please, Katy.
That's one.
So that leaves me to thank Katy especially for sharing your wisdom and experience, and for Ben and Hannah Gormley for supporting this presentation. The webinar has been recorded and will be uploaded to the RCOT website once subtitles have been added, and we will also share some of the links that Katy's included in the presentation so that you can access those directly as well. So thank you all for taking part today. We look forward to seeing you again at a future Neonatal Clinical Forum event. Enjoy the rest of your day.
Thank you.